We're now going to discuss common neurologic issues in pediatrics. We'll start with the CNS anomalies, central nervous system. First is the neural tube defects. This is a spectrum of disease. The mildest form is the spina bifida occulta. Basically there you just see a defect in the vertebral arch. There will be no extrusion of tissue, and there are no neurologic abnormalities. Many times you will see a little dimple or a tuft of hair overlying the midline defect, but otherwise patients have no issues. On occasion you will see an x-ray that shows a defect in the vertebral arch. Sometimes that's just gotten for a different reason and you pick it up. So it's really a very benign disease. Tethered cord means that the filum terminale of the spinal cord is basically anchored and can cause some problems. It can cause bladder problems and lower extremity problems. You will also sometimes see the midline skin lesion. These patients will need an MRI of the spine. That is the best test, and it really delineates the tethered cord, and then they would need surgery to release it. Here is an x-ray. The arrow shows a defect in the vertebral arches, and that goes along with spina bifida. This is an ultrasound in utero, a fetal ultrasound, and you can see this area right here is the spine. There is a little bit of a defect here, and then you have this whole area that is extruding outward. This is a meningocele. So this is a more severe form of the what we call the spinal dysraphisms. The spinal dysraphism, the mildest, is the spina bifida, but it can progress to meningocele and myelomeningocele. And this is a meningocele which is diagnosed in utero. This is a dermal sinus tract. Now, this could be, right there, that little dimple, that could be a blind pit, and that could just be the overlying defect that's associated with spina bifida occulta. However, it could be deeper and actually extend to the spinal canal. And you have to actually look real hard, and if you see that that's blind, then there's nothing else that needs to be done. The meningocele, the meninges actually will protrude through that defect in the vertebral arch. It'll be a midline mass and a very thin skin. These patients need MRIs. That shows you the extent of the involvement. They also need a head CT scan because many of these patients have hydrocephalus, and then they eventually need surgery to close up the defect. The myelomeningocele, remember that the midline defects can be prevented with folate during pregnancy. So that's a very preventable disease, and if the mom is taking folate with her prenatal vitamins, there's really decreases the risk of having these defects. The myelomeningocele usually is lumbosacral, but can occur anywhere along the old neural tube. It can, depending on its location, it can affect different nerves, and so they'll have different presentation. Many patients that have the myelomeningocele will have a type 1 Chiari malformation. These patients require an MRI, and they all require head CTs to look for hydrocephalus and any other malformations. They require surgery to have the meningocele or the myelomeningocele closed. If they have a hydrocephalus, they will most likely need shunting of the hydrocephalus. These patients will, many of them, depending again on the level, but most of them will have bowel and bladder problems. With bladder problems, this puts them at increased risk for urinary tract infections. They have what's known as a neurogenic bladder. The bladder doesn't empty normally, and they are having urinary stasis, which increases the risk of urinary tract infections. They can also have chronic constipation. Patients with myelomeningocele and these severe neural tube defects, you should automatically assume latex allergies with them. Because there's a higher risk for them, and one reason is they have multiple surgeries. They're exposed to latex a lot, and they can develop latex allergies. This is a child with meningocele. You can see the defect down here, but also there's actually another one up here. Anywhere along the neural tube, they can have this defect. And here you can see that there's actually a herniation of the structures outward. They have to be basically put back in a skin flap made for them. This is a myelomeningocele. So now you have, again, this is lumbosacral. This patient will have actual parts of the spinal cord coming through. So they have the meninges and nervous tissue herniating through that defect in the vertebral arches. Hydrocephalus results from impaired circulation or absorption of the cerebrospinal fluid. It can also be made, can also occur secondary to increased production of cerebrospinal fluid. And we classify hydrocephalus into what we call obstructive, which is a non-communicating hydrocele, or non-obstructive, in which there is a communicating hydrocephalus. The clinical presentation depends on the rate of rise of the intracranial pressure. So if it's a slow rate of rise, then it's more of an insidious presentation. If it's a rapid rate of rise, then you'll see more clinical signs and symptoms like vomiting, headache, whatever. Remember, the Chiari malformations can be divided into type 1 and type 2. Type 1 Chiari malformation is usually seen in adolescents, and they have really no hydrocephalus, whereas type 2 is going to be associated with hydrocephalus. The Dandy-Walker malformation is this cystic expansion of the fourth ventricle, and that is a form of hydrocephalus. The treatment of hydrocephalus is going to be shunting. Use of medications to decrease the risk, the production of cerebrospinal fluid really aren't very helpful, and so we tend to shunt the patients with a ventriculoperitoneal shunt. Sometimes hydrocephalus can occur after an intraventricular hemorrhage or after meningitis, because now the arachnoid villi are impaired, and that's where reabsorption of the fluid takes place, and so they can develop hydrocephalus. Here you have a child, younger child with hydrocephalus. One of the things you can look at is if the head is growing quickly, too quickly. So you look at rate of head circumference increase. Also, you can see some dilated scalp veins. You can see these veins right through here and through here, coming up this way, and here's another one. So look for dilated scalp veins. Patients with hydrocephalus can also have large fontanelles. You can palpate split sutures. Patients may have what's known as the sun-setting sign, and that's where the eyes are actually facing downward. A CT scan is the best test, and it shows this area of hydrocephalus. This whole area right there is all expanded, dilated. That's all hydrocephalus. And another example of hydrocephalus on CT scan.